Hello everyone. In this video, I will be discussing about hyponatremia. It is a very commonly asked topic, but you never read this topic from the chapter Endocrinology. First of all, let us see what is the definition of hyponatremia. It is plasma concentration of sodium less than 135 millimole. Remember, it is a very common disorder which occurs mainly in hospitalized patients. The reason for this hyponatremia is because of the increased arginine vasopressin, so called as AVP, or because of increased renal sensitivity to AVP, along with increased intake of free water. So these are the possible mechanism behind hyponatremia, which we will be discussing in detail. Hyponatremia can be broadly classified into hypovolemic hyponatremia, euvolemic hyponatremia, and hypervolemic hyponatremia. Hypovolemic hyponatremia means what? The principal culprit is increased circulating levels of arginine vasopressin. So this increased circulating vasopressin will preserve the blood pressure via vascular and baroreceptors, which are V1A receptors, and via V2 receptors it increases water reabsorption in the kidney, especially in the DCT and the collecting duct of the kidney, and that lead to hyponatremia in the setting of increased free water intake. So this is called hypovolemic hyponatremia. And what are when it comes to hyponatremia, the first system which has to be suspected, it is always kidney, renal. Suppose the non-renal causes, if you just evaluate, it is mainly GI causes, vomiting, diarrhea, or insensible water loss like sweating, burns of sodium and chlorine. Again, this hypovolemic hyponatremia can be classified, the causes can be classified based on whether the urea sodium is less than 20 or when the urea sodium is more than 20. That we will be discussing soon. So when it comes to renal cause, remember it is mainly because of an inappropriate loss of sodium chloride in the urine. So that will cause volume depletion, that will cause an increase in circulating AVP. So the urine sodium concentration will be more than 20. And this is mainly responsible for hypovolemic hyponatremia renal mechanism. And whenever deficiency in circulating aldosterone, it again causes the same hyponatremia as in case of primary adrenal insufficiency. So these are the various causes. Let us see hypovolemic hyponatremia. When the urine sodium is more than 20, it is always, remember, it is kidney. Renal cause, diuretic excess, mineralocorticoid deficiency, that is primary adrenal insufficiency, cerebral salt wasting syndrome. I have discussed what SIADH, which is a separate topic. You can find it in a separate video under this playlist. So when the urine sodium is less than 20, think about extrarenal losses like vomiting, diarrhea, burns, pancreatitis, trauma. When it comes to euvolemic hyponatremia, remember the urine sodium will be more than 20 in all cases, because the total body water is high, there is no edema at all. It occurs in case of glucocorticoid deficiency and SIADH. Yes, SIADH, syndrome of inappropriate antidiuretic hormone secretion. It is one of the most common cause, most common etiology to be evaluated when we suspect a case of euvolemic hyponatremia. And hypervolemic hyponatremia means what? Yes, there is increased total body water, and at the same time there is increased total body sodium. So you can see this, it is in this case, that is in hypervolemic hyponatremia only, the total body sodium is increased, whereas in case of hypovolemic and euvolemic hyponatremia, the total body sodium is either decreased or it is in the normal level. So just remember this. And when it comes to hypervolemic hyponatremia, again urine sodium more than 20, acute or chronic renal failure, in cirrhosis, cardiac failure, and nephrotic syndrome can cause hypervolemic hyponatremia with urine sodium less than 20. So when it comes to hypervolemic hyponatremia, as I told you, there is increased total body sodium chloride. As I told you, this is the only condition where the total body sodium is actually increasing. So this is accompanied by what? So when more sodium enters in the body, more chloride enters in the body, proportionately greater water increase in the body. So as a result, what? More water means what? Sodium levels fall. It is what to say? It appears to fall, even though the total body sodium is high, because of increased water in that increase the total body water. Actually, there is more water and the sodium appears to fall. So despite of having high sodium, there is hyponatremia. That is why it is hypervolemic hyponatremia, because of more water. And coming into euvolemic hyponatremia, see, as I told you, the causes of euvolemic hyponatremia, it is the first and foremost cause, it is always SIADH. And another one is glucocorticoid deficiency. As it remember, mineralocorticoid deficiency, that causes actually what? Hypovolemic hyponatremia, whereas glucocorticoid deficiency, one and only glucocorticoid deficiency is there, it causes euvolemic hyponatremia. And as I told you, SIADH is the most frequent causes of euvolemic hypovolemic hyponatremia. Fine. When it comes to the other intake, that is because of low solute intake and hyponatremia. Yes, because the patient will have very low intake of dietary solute, as in the case of beer potomania, which is a condition in which there is a decreased intake of dietary solute. Again, it causes hyponatremia. Okay. Yes. So these are the causes of SIADH. This is a different topic which I have discussed in detail. So coming into the clinical features, remember, so what is actually happening? More water is in these. So hyponatremia induces cellular swelling because of the water movement down the osmotic gradient. Okay. So what? It will be primarily hyponatremia means always the first system to come in by the CNS. Okay. That is neurologic, which develop in the form of cerebral edema within a rigid skull. Skull is rigid now. Within that swelling happens. So what? That is called cerebral edema. So initial CNS response to hyponatremia will be what? There is an increase in interstitial pressure. There will be leading to shunting of extracellular fluid and solute from the interstitial space into the CSF and then into the systemic circulation, which manifests in the form of cerebral edema. And the second complication of acute hyponatremia is respiratory failure. Remember. Okay. So see, when it comes to hyponatremia, it may be either acute hyponatremia or chronic hyponatremia. Most of the cases are acute chronic hyponatremia. For example, this SADH, glucocorticoid deficiency, the renal failure, all those causes chronic hyponatremia. Because acute hyponatremia, it is usually having an iatrogenic component because of the more when we give more hypotonic IV fluids to the post-operative patient, this will cause an increase in circulating arginine vasopressin. That in itself causes hyponatremia. Okay, so this is an acute hyponatremia. Remember, the treatment of choice in acute hyponatremia is always 3% hypertonic solid, NS saline. And when it comes to, as I told you, it is iatrogenic, recent institution of thiazide diuretics, polydipsia, and MDMA drug, exercise-induced hyponatremia. All those are possible causes of acute hyponatremia. And remember, when it comes to the diagnostic approach to, see, actually, as I told you, the most common presentation will be always of chronic hyponatremia, because unless the causes of acute hyponatremia is very less, okay, most of the cases we see will be like a case of an chronic hyponatremia. In that, we have to be always very careful while we do correction in case of chronic hyponatremia, because overly rapid correction means what? We are correcting more than 8 to 10 millimoles of sodium in 24 hours or 18 millimoles in 48 hours. It will cause hypertonic stress, especially within the astrocytes of the brain, which leads to a condition called as ODS. What is ODS? Osmotic demyelination syndrome. Okay, it leads to it's actually something called as an ER stress. In pathology, you would have read about endoplasmic reticulum stress response. Because of that, there will be osmotic demyelination of the pons. This is also called a central pontine myelinosis, which presents 1 or more days after the overcorrection of hyponatremia, and the patient usually have so-called as a locked-in syndrome, that is dysphagia with the paraparesis or quadriparesis, diplopia, or loss of consciousness. Okay, this is osmotic demyelination syndrome. Remember, the always question that asked in PG exams also, what is the investigation of choice for osmotic demyelination syndrome? It is an AIMS PG question, okay, asked last year. It is always MRI. So coming into diagnostic approach to hyponatremia, the first thing, laboratory, we have to always exclude pseudo-hyponatremia. What do you mean by pseudo-hyponatremia? That is, with the hyponatremia will be present along with the normal or an increased plasma tonicity. Okay, that is actually called a pseudo-hyponatremia. So always we have to exclude a pseudo-hyponatremia. Whenever there is associated elevated blood urine nitrogen and creatinine, we have to always think about it. As I told you, when it comes to acute hyponatremia, we have to rule out the iatrogenic causes. When it comes to chronic hyponatremia, first SIADH, then we have to think about the renal dysfunction, because it is a most common cause of hyponatremia. And when it comes to hyperkalemia with hyponatremia, always think about hypoaldosteronism or primary adrenal insufficiency. Remember, salt or the mineralocorticoid deficiency causes something called as hypovolemic hyponatremia, whereas the euvolemic hyponatremia is caused by so-called as glucocorticoid deficiency, then of course our hypothyroidism also. When it comes to treatment, symptomatic acute hyponatremia, don't wait and watch, because his brain is going to get affected anytime soon. So always treat with 3% hypertonic saline. Okay, so nausea, vomiting, seizures, central herniation, headache. As far as CNS is the first system to be affected in case of hyponatremia. As I told you, don't correct more than 8 to 10 within first 24 hours or more than 18 within first 48 hours, because it leads to something called as ODS. Investigation of choice is MRI. 1 or 2 days after the patient may present with paraparesis, quadriparesis, so-called as locked-in syndrome. Yes, and yes, with that, I think we have come into the end of this discussion on hyponatremia. Remember, acute hyponatremia, symptomatic 3% hypertonic saline. Remember, ODS, investigation of choice, MRI. Remember, causes of acute hyponatremia, iatrogenic, MDMA, exercise-induced, and all those things. Then coming into clinical features, it is CNS, respiratory failure, and cerebral edema. Okay, and beer potomania, it is because of low solute intake. And remember this table, hypovolemic, euvolemic, and hypervolemic. Hypervolemic hyponatremia only, this is the condition where the total body sodium is high despite despite there is hyponatremia. Okay, despite high total body sodium, there is hyponatremia. And when it comes to hypovolemic hyponatremia, remember mineralocorticoid deficiency, pure glucocorticoid deficiency, SADH. Yes, SADH is one of the most common cause of euvolemic hyponatremia. For detailed information about SADH, I strongly recommend you to watch the separate video on my playlist. Thank you.